All right, so we're going to get started pretty soon. I'm just going to wait for a couple more people to log into the session. And as soon as we start getting questions submitted over here, then we can start with the Q&A. Feel free to enter in any questions that you guys have at this point, and we'll answer them slowly as we go through the webinar. All right, so we have a couple more people logged in here and I'm starting to get some questions. So let's just dive into this and we can go through these one by one as we go through. So just to introduce myself, I'm Dr. Cassandra Greenberg. I'm one of the reproductive endocrinology and infertility specialists here at Trio Fertility. So let's just jump right in and start with some of the questions here. So the first question I have here is, will Trio disclose the sex of an embryo that's currently frozen? So this really goes back to the Assisted Human Reproduction Act in Canada. So it's actually illegal in Canada to do sex selection, meaning that we can't select to transfer embryos based on gender. And that's Canadian law, that's not clinic specific. So as far as I know, there are no exceptions at Trio where we're able to disclose the sex of an embryo while it's still frozen. All right, so the next question we have here are, what are the clinic success rates with using egg donors at age 46? Really, when you talk about success rate of an egg donor, it's really going back to the age of the egg donor rather than the age that you're using the eggs at. And at our clinic, our success rates with egg donors are quite high. In terms of pregnancy rate, probably somewhere around 40 to 45% at least. And then live birth rates are somewhere similar to that. Next question we have here is there a blood test to confirm ovulation? If so, does that assist in determining future treatment options or diagnosis of infertility? And is that an option at the clinic? So when we talk about testing for ovulation, that often goes back to either cycle monitoring, where we do regular blood work and ultrasound to see how many follicles are developing in that early follicular phase, the first phase of the menstrual cycle, the blood work showing how estrogen is rising. And then the hormone that tells us that ovulation is happening is a hormone called LH, luteinizing hormone. Once we see the LH rise or peak mid-cycle, that tells us that ovulation is happening. There's no kind of individual blood test that tells you about ovulation. You really have to be able to do the LH test at the exact right time in the cycle, which can be hard to do without cycle monitoring. We don't necessarily do cycle monitoring as part of a diagnostic piece of determining if that is the cause of fertility issues. Generally, just looking at the history of menstrual cycles will tell us that ovulation could be part of the problem. So for example, if someone has irregular cycles, that's often an indication that ovulation is not happening regularly. and then we can target some of the treatments towards getting regular ovulation. I hope that answers your question. If I didn't, maybe just submit another one if you want to clarify. So the next question I have here are, what are some things to do to help with implantation? Are there certain activities, foods, or supplements that can thicken uterine lining? So I'm assuming that we're talking about potentially a frozen embryo transfer in terms of improving success rates prior to doing an embryo transfer. In terms of activities or lifestyles, there's really nothing specific in terms of specific exercises or diets that help with improving the success rate of embryo transfer. In terms of lifestyle factors, I would say just try and have a healthy diet and a healthy lifestyle to prepare your body for pregnancy. Similarly, supplements-wise, really the only supplements that you would need kind of leading up to embryo transfer or after embryo transfer are really just a prenatal vitamin. Those would be really the main vitamin that I would recommend just in preparation for pregnancy. Sometimes things that can be helpful are things like vitamin D just for general health. And in terms of things that would help thicken uterine lining, there aren't too many kind of natural options to thicken up uterine lining. We really use mostly hormonal treatments if someone has a thinner lining and we're trying to thicken the lining during the cycle. So that can either be estrogen tablets or medications that would help improve ovulation, or sometimes our injectable medications can sometimes help improve uterine thickness. But otherwise, foods, supplements, diet, exercise don't have a big role to play in terms of uterine lining thickness. The next question I have here is, can I request for 2 embryos to be transferred at once if I'm hoping for twins? So this is a little bit of a complex question. The short answer would be yes, there is an option for a double embryo transfer at Trio, but it would really depend on your own specific situation, your doctor's comfort with transferring 2 embryos, whether or not you're using genetically tested embryos or untested embryos, your age, and whether or not you're doing a funded cycle, because there are specific regulations with funding about whether or not we can transfer 1 or 2 embryos at a time. Now, in terms of hoping for twins, we do know that multiples are a side effect of fertility treatment, so it can happen when you're doing IVF or embryo transfer. Generally, our goal is 1 healthy baby at a time. So we don't generally aim to have a twin pregnancy, but we recognize that can happen with fertility treatment. Next question I have here is, I have a hydrosalpinx that has been blocked with fill sheet clips. Can I proceed to transfer? So just to give a bit of background info here, hydrosalpinx is where the tubes are dilated and they have fluid within the tubes. The reason that we get so concerned about this with respect to embryo transfer is we don't want that fluid that's sitting in the tubes to then affect the embryo, potentially could be toxic to the embryo, or other theories could be flushing away the embryo from inside the uterus. So the goals when you have a hydrosalpinx, either one or both, and you're planning on doing an embryo transfer, is we need to interrupt the pathway of that fluid between the tubes and the uterus. So that can either be, most commonly, it would be something like a salpingectomy, where the tubes are actually removed and that fluid is taken out. Depending on your doctor, your surgeon, or your own particular scenario, removing the tubes might not necessarily be an option. And so fill sheet clips are an alternative just to interrupt that flow between the fluid in the tubes and the uterine cavity. So as long as your tubes have been blocked off and there's no way for that fluid from inside the tubes to get inside the uterus where we're going to place the embryo, then I don't see a reason why there would be a problem proceeding with embryo transfer. Next question, with multiple frozen embryos, how does Trio determine which embryo should be transferred? So again, a little bit of a complex answer here, and it really does depend on your own particular situation. For example, if you have genetically tested embryos, we would transfer the normal embryos first. So we wouldn't transfer any mosaic or abnormal embryos. If you haven't done genetic testing on your embryos, then often our embryologists will use a couple of different pieces of information to really try and determine which embryo is likely going to give you your best chance of success. So that could be the grading of the embryo, so that combination of number and letters of the embryo, that will help determine which embryo the lab will thaw first. Sometimes the day of freezing, so whether or not it's a day 5 or a day 6 embryo, can help determine which embryo they would thaw first. And if you've elected to do the embryoscope as part of your cycle, sometimes the lab will also use information from the embryoscope to determine which embryo has a better chance of success. Next question here, block tubes seem to be a popular diagnosis, but then it's also not confirmed. Is there a test that can confirm this? And what are your success rates with one block tubes trying naturally, and can we unblock tubes at all? Okay, so let's kind of tackle this step by step. So yes, block tubes can be popular. The most common test that we do to get an assessment of anatomy, meaning the uterine cavity and the fallopian tubes, is a sonohistogram that most people refer to as the water test, where we put water inside to see if the tubes are open or blocked. When you say that the tubes might not be confirmed, sometimes you can have something called tubal spasm. What that means is when we put the fluid inside, we might not see the fluid flow through the tubes. That flow through the tubes tells us that those tubes are open. If the tube is truly blocked, then the fluid won't flow through. But if the tube is in spasm, so think about like a muscle spasm, if that tube is in spasm, the muscle might close down around it, and it might appear that the tube is blocked, even if in reality it's actually open. The only way to confirm whether or not a tube is truly blocked versus if the tube was just in spasm and it appeared blocked at the time of the sono is to redo the sono to see if on a second exam, does it still look like the tube is blocked. If you have two sonos showing that a tube or both tubes are blocked, it's generally fairly likely then that tube is truly blocked versus tubal spasm. And then, is there a test that can confirm this? So a repeat sono would be one test that could confirm whether or not a tube is truly blocked. Another test that I don't particularly do in my practice, but is available at kind of a few places, I suppose, in the city, is something called a hysterosalpingogram, or an HSG, sometimes referred to as. This uses contrast dye as opposed to water and an X-ray as opposed to an ultrasound to see if the tubes are open. And what are your success rates with one block tube trying naturally? So really your success rate in terms of trying naturally shouldn't really be affected by having one block tube. The information that we use to make that judgment is for people, for example, who have had an ectopic pregnancy and have one tube removed, because that's where the pregnancy was, and they only have one fallopian tube remaining, research actually shows fertility isn't decreased at all. So having one block tube shouldn't have a big impact on your natural chances of success. And then can we unblock tubes at all? So the short answer would be that depends. It depends on where the blockage is. If the blockage is at the end of the tubes, like at the very end of the tubes where the fluid spills out into the body, sometimes there is an option to open up the tube from the end, and that way that can unblock the tube. If the tube is blocked closer to where it meets with the uterus, it can be a little bit harder to unblock the tubes. This is a little bit of an older procedure that not a lot of physicians are doing anymore. So the short answer would be yes, but it could be hard to find somebody to unblock a tube just because it's less common of a procedure. Next question, any feedback on vitamin E and L-arginine supplements for lining issues? I haven't used this in my practice, and I'm not familiar with any specific research specifically focusing on vitamin E and L-arginine specifically for lining issues like thin lining. I will say that we do have naturopaths that work alongside our clinic. And if you have any questions, any of our patients are always welcome to chat with Conceive Health, to chat with our naturopaths about supplements that might be recommended for you. What is considered an irregular cycle? So a regular menstrual cycle would be basically a cycle that's happening monthly. So the classic sort of textbook definition of a regular cycle would be every 28 days. There's actually very few people who have a true 28-day cycle every single month. Generally, we say as long as it's 28 days plus or minus 7 days, that would be considered a regular cycle. If you have more variability beyond 7 days in your menstrual cycle, that would be considered an irregular cycle. Next question here, can a retroverted uterus affect pregnancy outcomes? No, retroverted uterus is actually quite common. I believe the stat is around 15% of our patients will have a retroverted uterus. Whether or not your uterus is retroverted, meaning pointing towards the back, or anteverted, meaning pointing towards the front of the body, that won't have an impact on whether or not you can conceive or outcomes during pregnancy. Next question here, how many months of trying to conceive naturally would you recommend prior to going to a fertility clinic? Also, is a doctor referral required? So yes, a doctor referral is required prior to coming to a fertility clinic. Most people will go to their family doctor and have a referral sent over. In terms of the length of time that I would recommend prior to coming to a fertility clinic, it really depends on the age of the female partner. So for example, for a female that's under the age of 35 and you've been trying naturally to get pregnant, generally say to try for about 12 months before coming to a fertility clinic. If you're 35 and over, then the wait time we recommend is shorter. So 35 and older, we would recommend trying for about 6 months and then coming to a fertility clinic if you're still not able to have success on your own. Over the age of 40, I would recommend even a shorter interval. So really, I would try naturally for about 3 months or so. And then if you don't have success naturally, coming to a fertility clinic, keeping in mind it might take time for you to see the fertility doctor, as well as to get all of the investigations sorted out. Now, also outside of age, there might be other reasons why someone might come to a fertility clinic sooner than those recommended guidelines based on age. So for example, if you have an irregular cycle, you might come to a fertility clinic sooner rather than later because it's harder to time trying to get pregnant naturally. Or if you have a diagnosis of something like endometriosis, something that's known to decrease fertility, then you might also come to a fertility clinic sooner than this, just those age-specific guidelines. What is the current average wait time for funded IVF? So that depends on the clinic. At Trio, our funded IVF wait time is somewhere between a year to a year and a half. Now, with that being said, I will say that sometimes patients are offered cancellation spots, meaning that if a spot becomes available, you might be offered a funded spot sooner than that 1 year to 1.5 year wait time. Next question, are there certain protocols that are chosen specifically for women over 40 years of age? Is it more of an aggressive protocol? So I think you're probably referring to an IVF protocol. Let me know if you're asking about a different protocol. This would really depend on your egg reserve testing. So things like your AMH blood tests, your follicle count, and things like your FSH values. Your egg reserve testing, meaning looking at egg quantity or the number of eggs that are in the ovaries, really determines how much medication you would use and how much stimulation you would get during an IVF cycle. I will say, though, most physicians would tend to err on the side of higher doses of medication at an age 40 and older, really just to try and maximize what we get from an IVF cycle. But if you have quite a high egg reserve, it won't be safe to give you high doses of medication because then we would increase your risk of something called hyperstimulation or OHSS. So it is a balance between your age and then the results of your egg reserve testing. After 3 natural miscarriages and 1 failed transfer with PGTA tested embryos, what's your recommended path forward for testing beyond ERA and an RPL blood panel? So this does end up being quite a complex and tricky question. It is going to be different depending on your specific scenario and your doctor's recommendations. With 3 natural miscarriages, and I'm sorry that you've had 3 miscarriages prior to doing IVF, generally the recommendation is to move forward with IVF and genetic testing of embryos. So you've already done that first step right there. That's because even with multiple miscarriages, the most common cause of miscarriage is going to be chromosomal abnormalities that lead to miscarriage. Those are abnormalities in the embryo, genetic abnormalities. So by doing IVF with PGT, you're already trying to increase your chance of success by pulling out the embryos that have normal genetics and hopefully decreasing your chance of miscarriage as well with that. PGT is not 100% accurate though. It is a very, very good test. but that doesn't mean your chance of pregnancy is 100%, and it doesn't mean the chance of miscarriage is 0%. And it's always a big disappointment when you don't have a pregnancy with a genetically normal embryo. Now, in terms of next steps, if you haven't had recurrent pregnancy loss testing already, it's probably a good idea to follow up with your doctor to see if there's any additional testing to round out that RPL blood work panel. I will make a comment about ERA. ERA stands for endometrial receptivity assay. This is a test that's done. It's a biopsy of the inside of the uterus during a mock embryo transfer cycle. So you would do an embryo transfer cycle exactly the way you would do it as if you were transferring an embryo. But on the day that you would put an embryo inside the uterus, instead of actually doing that embryo transfer, we take a sample of the tissue of inside the uterus for something called receptivity. That test tells us whether or not that's an appropriate amount of progesterone, whether there's too much progesterone or too little progesterone, and we need to alter the day of embryo transfer. The research around ERA has really gone back and forth over the couple of years that it's been available. Most recently, there was a study that came out, though, that showed that ERA wasn't necessarily increasing the likelihood of success in terms of pregnancy outcomes with a frozen embryo transfer, and could actually lead to harm, meaning decreasing pregnancy rates when you're using ERA. And so since that study came out a couple months ago, I think most physicians at Trio have actually stopped doing ERA. So that's just one comment about that particular test. There are a couple other tests that you could talk about with your doctor. So something called an Emma Alice biopsy is something different than receptivity. It's looking at things like signs of chronic infection inside the uterus, signs of an imbalance in the microbiome inside the uterus. So think about that as good bacteria and bad bacteria. We often think about the balance of good and bad bacteria in the gut, but the same idea actually exists inside the uterus. And so as opposed to something like an ERA biopsy, your doctor might offer you an Emma Alice biopsy to see if there's anything there that needs to be treated or rebalanced before trying for another embryo transfer. So I hope I answered your question there. Next question, does the clinic do any repeat or additional after a certain amount of time with no success, or when the treatment changes? So maybe you could resubmit the question. I'm not sure what question you're asking here. Like, do you do any repeat or additional testing? Or are there other treatments? If you don't mind resubmitting the question and let me know specifically what you're asking. Next question, is CoQ10 recommended to boost both egg quality and sperm quality? So yes, CoQ10 is often used for a lot of female patients to help improve egg quality. Even if we don't suspect that you have an egg quality issue, so for example, if you're nice and young, a lot of us will recommend using CoQ10 as a supplement to help improve egg quality, specifically before something like an IVF cycle. CoQ10 is also used for sperm quality as well to help improve sperm quality, which has been shown to have impacts on the outcomes and success rates of an IVF cycle. Most commonly, the supplement that we do tend to recommend for sperm quality is a product called Fertile Pro for men, probably the most common fertility supplement that we use for our male patients, that includes CoQ10 in it, but also has a lot of other nice supplements that can also help improve sperm quality. What is the chance that a day 5 embryo from a 40-year-old woman will lead to a healthy baby, and for a day 6 embryo? So the stat that I often refer to with IVF success rate and age is overall the likelihood that IVF will lead to a live birth, so a healthy live baby over the age of 40, is less than 20%. This really depends on your own situation, how old you are, what the quality of your embryos are, whether or not they're genetically tested. So a lot of that really depends, or the success rate really depends on a lot of those different factors. Next question, can sperm DNA fragmentation results be shared with the patient? Yes, so if you have done sperm DNA fragmentation, that result is often shared with you at your first follow-up with your fertility doctor when we review all of your results. If you're asking if your partner's sperm DNA fragmentation can be shared with you as the partner, then we do have forms that are available in the clinic where your partner can sign off on disclosing your results to you. And then the doctor is able to send you the results as long as the person doing the DNA fragmentation has consented to that. Can sperm concentration and morphology be improved through lifestyle changes and/or supplements? Any specific supplement brand that you recommend? So we did touch on Fertile Pro already in terms of the supplements that can be helpful for sperm quality. But in terms of whether or not concentration and morphology can be improved with lifestyle changes and supplements, absolutely yes. Lifestyle is probably one of the biggest things that could impact sperm quality. And that could be sperm concentration, also known as sperm count or sperm number in the sample. Sperm morphology, meaning the appearance of the sperm in the sample, so whether or not they look normal versus abnormal. Lots of different lifestyle things that could impact sperm quality. So some of the big things that we think about: smoking cigarettes, big impacts on sperm quality, could lower sperm counts. Sperm motility could alter morphology, could increase DNA fragmentation. Alcohol use. Now, alcohol, in terms of its impact on sperm quality, if you're following those new Canadian guidelines where they recommend no more than 2 alcoholic drinks a week, that amount probably isn't going to impact sperm quality. But if you're well above that, like if you're having 8, 10, 15, 20 alcoholic drinks per week, that can have a significant impact on sperm quality from all angles. That could be sperm count, motility, morphology, DNA fragmentation. All of those things can be affected with high alcohol intake. And then also recreational drug use. So specifically, we actually focus on marijuana use. Marijuana has been shown to have an impact on sperm quality, all of those parameters that I've already mentioned. Count, motility, morphology, DNA fragmentation can all be impacted by marijuana use. Another lifestyle factor that can impact sperm quality that sometimes is missed, and we don't necessarily think about it in weather like this, is heat exposure. So regular hot tubs, regular sauna use, laptops on the lap, heated car seats is one that's often forgotten about, especially during the winter time. All of that heat exposure can impact sperm quality as well. So cutting out things like hot tubs and saunas can improve sperm quality. The other thing that's a little bit similar to the heat exposure is sometimes BMI can actually affect sperm quality as well. So having a BMI kind of in the overweight or more so obese category can also affect sperm quality as well. So similar question here: what are the treatment options for a 0% sperm morphology, and could IUI be considered for low morphology? So just focusing on sperm morphology for a second, like I mentioned earlier, morphology is the appearance of the sperm under the microscope. So whether or not the sperm look normal versus abnormal. Now, in order to be considered a normal sperm sample, you only need to have 4% normal looking sperm to be considered normal. So on the flip side of that, you can have 96% abnormal sperm and still be considered normal. When our lab is assessing sperm morphology, the andrologists don't look at the entire sperm sample and see what percentage of sperm look normal or abnormal. They take a small volume of that sperm sample and they use that as a representative sample of the entire semen collection to see, are there normal or abnormal sperm there? So if you have a result back that shows 0% sperm morphology, that doesn't necessarily mean there are 0 normal sperm in the sample. It just means that in that representative volume that the andrologist looked at, there was no normal sperm there. In terms of treatment options, things like insemination, IVF with ICSI are all options for a 0% sperm morphology. This doesn't necessarily mean that you automatically have to go to IVF, assuming the other parameters are appropriate. For example, both fallopian tubes or one fallopian tube is open, the count of the sperm is appropriate, the motility of the sperm is appropriate. That is still an option to do IUI if morphology is the only abnormality. If you are progressing to IVF, generally ICSI, intracytoplasmic sperm injection, which is where the sperm is injected into the egg for fertilization, it would generally be recommended if you are pursuing IVF. Can egg quality be improved? Definitely, we touched on this a little bit. So things like supplements can help improve egg quality. Things like prenatal vitamins potentially can help improve egg quality. Coenzyme Q10, a vitamin that you can pick up in any vitamin aisle, can help with egg quality. Vitamin D has also been shown to be helpful for egg quality as well. And then the second part of this question here, could a short luteal phase, somewhere between 10 to 12 days, mean poor egg quality? So short luteal phase is one of those things that is a little bit complex, and there isn't a ton of convincing research about short luteal phase. So the luteal phase is the second half of the menstrual cycle after ovulation. The average time, or the kind of classic time of a luteal phase, is about 14 days, but that doesn't mean that's the only period of time of the luteal phase that's considered normal. Actually, as long as the luteal phase is 10 days or more, it's actually considered a normal luteal phase. If it's 8 or 9 days, that might be considered shorter. A short luteal phase hasn't necessarily been shown to be linked specifically to egg quality. More likely, it could either be something idiopathic, meaning that we don't necessarily know the cause of why the luteal phase is short, or it could be related to more of an ovulation disorder. So if ovulation isn't happening regularly, that could lead to a shortened luteal phase as well. And another funded IVF question here, if you have a canceled funded cycle just prior to egg retrieval due to early ovulation, do you have to be put back on the wait list? Now, with funding, so the guidelines around funding is once you start a funded IVF cycle, that is your first attempt at funding. So doing your injections and stimulation would be your first attempt at funding. If the cycle is canceled before you have your egg retrieval, you still have a second attempt at funding. The Ontario government will only allow 2 attempts at funding. So once you start your second funded attempt, you don't get a third or a fourth attempt. Once you've had an egg retrieval, that's when your funding has been used. So for example, if you have an egg retrieval and unfortunately didn't get good outcomes, you don't get a second attempt at funding. Now, in terms of when the second funded attempt happens, if your first cycle is canceled because you've ovulated through your medications and you haven't gotten to the point of egg retrieval, you don't need to go back on the wait list and wait that extra year or a year and a half. Often what you will do is have a follow-up with your doctor so that you guys can change the protocol or talk about what protocol will be recommended for you for your second attempt. But that doesn't necessarily mean you have to wait the full year to try funded IVF again. All right. How many IUIs would you recommend prior to moving on to IVF? So generally, I would recommend doing at least 3 IUIs or so before moving on to an IVF cycle. And that's because the research shows us that it's about 3.5 IUI cycles where you see the success rate slowly increasing, like the line slowly increasing in terms of pregnancy rate. But once you've gotten to about 3 or 4 IUI cycles, that success rate really plateaus off. So doing further IUI cycles doesn't necessarily increase your chance of success. So most physicians after 3 IUI cycles would recommend moving on to IVF because you don't necessarily give yourself a higher chance of success by doing further cycles. Next question, are extra hormones used during mock transfers? So again, this is one of those questions that depends on your own particular protocol. A mock transfer would basically be like a practice frozen embryo transfer. So it really depends on what protocols your doctor has recommended for you for frozen embryo transfer. So there are essentially 2 different kinds of embryo transfer protocols. One of them would be medicated, which is kind of a classic frozen embryo transfer protocol where we use hormone replacement therapy like estrogen tablets to thicken up the lining of the uterus. And then on the flip side of that, as opposed to hormone replacement, we also do ovulatory cycles, which may require no medications at all. It might require some tablet medications just to induce ovulation, or sometimes injectable medications to also help improve ovulation. So if you're doing a mock transfer, your doctor's probably going to recommend whatever is planned for your future frozen embryo transfer. That's the protocol that's going to be used for your mock transfer, but it doesn't necessarily have to be hormone replacement. I've seen a lot in the online community regarding taking baby aspirin during a transfer cycle. Is there any science backing this? So this is something that's sometimes added on with a frozen embryo transfer cycle. Really, the data that's around aspirin and doing a frozen embryo transfer isn't really convincing either way. Potentially, it could be helpful in terms of lining thickness or success rate with the frozen embryo transfer. It's not really clear whether or not it's truly helpful or not. But on the flip side of that, it also hasn't been shown to cause any harm. So sometimes this is an option if, for example, you've had a failed cycle or if you only have one embryo frozen. Sometimes this is something that we add on to the cycle to hopefully try and improve success rates. And here, oh, so this is the previous question. Sorry, I meant, does the clinic do any additional or repeat testing if you have done treatments with no success, such as timed intercourse and/or IUI, and now you're thinking of IVF? Will additional tests be done to see if there are any changes? So if, for example, you've seen your fertility doctor and you've done your initial investigations and a long period of time has gone on where you've done timed intercourse cycles or IUI cycles, and now you're planning an IVF cycle, your doctor might update some of your investigations to try and dose your medications or pick the protocol that's most appropriate for you during an IVF cycle. So some of your investigations might be updated before doing an IVF cycle. Sometimes we might do some more specific sperm testing. So the DNA fragmentation test that's been mentioned a couple times. If you haven't done that already, sometimes we will repeat a semen analysis specifically to look at DNA fragmentation. Because it's been shown that if DNA fragmentation is elevated, this is a number that you would want to be low. If it's high, that could impact how the embryos develop in the lab. So that might be some additional information that your doctor would want prior to doing an IVF cycle. What is TRIO's success rate for surrogates? I assume it's different than the IVF rate. It's probably quite similar because, again, a lot of the success rate around embryo transfers and IVF success is really related to the age of the female partner at the time that the embryo was created. So, for example, if the embryo was created with 35-year-old eggs, but they're now being used in a 40-year-old woman, for example, the success rate will be consistent with someone who's 35 years old. Similarly, if an embryo was made at someone, let's say, for example, 38 years old, but you're using a surrogate who might be 32 years old, the success rate would still be consistent with someone who's 38 years old. Now, I will say that if, for example, you've done multiple embryo transfers and you haven't been able to get success, and there might be a uterine factor involved, if you and your doctor think there might be some kind of uterine factor, the success rate might be higher in a surrogate who has already kind of had a pregnancy and had a delivery. You might increase your chance of success in that way. But mostly when we talk about the success rate of IVF, it really is related to the age of the egg at the time that the embryo was created. Is there a better success rate between day 5 or day 6 embryos? So yes, so there is some research showing that day 5 embryos do tend to have a slightly better success rate compared to day 6 embryos. That's not necessarily like a huge difference, for example. So if you have genetically tested embryos, whether or not you have a genetically normal embryo created on day 5 or day 6, that's probably not going to impact your success rate at that point. But if, for example, you have a high quality day 5 embryo in terms of its grading and a high quality day 6 embryo, when you compare those two together, the day 5 embryo will probably have a higher success rate compared to an embryo on day 6, for example. What makes you a good candidate for an IUI if you have had failed or are waiting for IVF? Is it worth trying, and why or why not? So in terms of what would make you a good candidate for an IUI cycle, so that would be having a normal uterine cavity, open fallopian tubes, and normal sperm counts, meaning normal semen analysis, meaning normal sperm counts and normal motility to make IUI an appropriate option. If you've had failed or you're waiting for IVF, is it worth trying IUI? When we think about fertility treatment, generally IUI, just overall for all comers, is going to have a lower success rate compared to a treatment like IVF, because we have less control over what's happening with an IUI cycle, compared to what's happening with IVF. For example, if you've already done an IVF cycle and you're thinking about maybe going back to IUI, That is definitely an option. There's no reason to say that's not an option if you have open tubes, for example, but often the success rate will be lower. So I would say that probably the most common scenario of going from an IVF cycle to an IUI cycle are often financial. So if, for example, you couldn't afford to do an IVF cycle, IUI is still an option for you because IVF is quite an expensive treatment. Or for example, emotionally, you can't tolerate another IVF cycle. IVF is a very intense process and it does involve a lot of up and downs in terms of emotions. And if you feel like mentally you just can't handle another IVF cycle, it is an option to go back to an IUI cycle. But when you compare the two treatments, IUI is going to have less success compared to IVF. Next question here, what FET protocol has been the most successful for a person with endometriosis? Can endometriosis affect implantation and how? And is there anything that we can do to ensure the most success for FET with endometriosis? So the first and third part of this question are pretty similar just in terms of the protocols for endometriosis. So one of the protocols that has been recommended for endometriosis, if, for example, previous frozen embryo transfer protocols haven't worked for you, down regulating something like Lupron prior to doing a frozen embryo transfer might be helpful prior to doing the embryo transfer to see if that could improve success. And also, depending on your situation and the severity of the endometriosis, sometimes your doctor might recommend surgical treatment of the endometriosis, especially if you have very severe symptoms from the endo. That is sometimes recommended prior to doing an embryo transfer, just to improve the environment in the pelvis in terms of like decreasing inflammation prior to putting an embryo back inside. So again, that is going to be a discussion between you and your doctor about what is most recommended. And then the middle part to this question, can endometriosis affect implantation and how? So in terms of the impact of endometriosis and fertility, endometriosis can lead to subfertility or infertility in a variety of ways. That could be with endometriosis, there might be scarring or inflammation in the pelvis. That scarring could potentially block off the fallopian tubes, meaning that egg and sperm couldn't come together naturally through the fallopian tube. That's one way that endometriosis can impact fertility, but truthfully, it's probably not the most common way that patients with endometriosis have subfertility or infertility. It's also been shown that endometriosis can lead to things like lower egg reserve, lower egg quality, impaired embryo development, impaired implantation. These have all been shown to be associated with endometriosis, but the exact reason why we don't necessarily have a clear answer. Probably something related to inflammation in the pelvis, but in terms of exactly how endometriosis could impact implantation, it's not really clear in terms of a specific answer. And next question, does drinking coffee daily have a negative effect on egg and sperm quality? Depends on how much. So generally for female patients trying for pregnancy, recommendation for caffeine is 1 to 2 standard cups of coffee per day, not more than that. In pregnancy, we recommend just 1 cup of coffee per day. So somewhere between 1 to 2 cups of coffee per day is probably okay while you're trying to get pregnant. But if you're having 3, 4, 5 cups of coffee, that actually can impact fertility, and I would recommend decreasing while you're trying for pregnancy. And next question here, is synthetic thyroid recommended if you're within normal range, but at the high end, 3.6 or higher? So thyroid and fertility and pregnancy has been quite a confusing topic because there's so much research that's gone back and forth over the years. Chatting with our endocrinologists, there are adjusted recommendations in terms of what's recommended and when to treat a thyroid level. So now what our endocrinologists are saying is the number that you're referring to, the 3.6 or higher, that to me looks like the TSH value. And our endocrinologists are now saying if your TSH is under 4, you don't need to treat that with exogenous thyroid hormone. If your TSH level is over 4, then it's worthwhile considering adding in some thyroid replacement to help with pregnancy and fertility outcomes. But really the number that we would be looking at is under 4 now. Whereas in the past, you might have seen reference to a TSH of 2.5 or higher would be recommended. That number has now increased and our endocrinologists are recommending under 4 do not need treatment. And the last couple of questions here, what are the tests involved to qualify for egg donation guarantee plan? This is actually separate from the fertility clinic. I think what you're probably referring to is the DEB-USA guarantee plan. They set their own criteria in terms of whether or not you qualify. It's actually totally separate from the fertility clinic. You should be able to get this information from the DEB-USA website. And if you're not able to, our third-party coordinator might also be able to give you that information. And the last question I have here, for an FET cycle, at what point do you or doctors change the IVF protocol if you've had a failed transfer? Would they repeat the same protocol if you've had a failed transfer? So it depends on someone's practice, but if you've done one frozen embryo transfer protocol and that hasn't been successful, often what you would do is have a follow-up appointment with your doctor to talk about changing the protocol for next transfer. Most physicians would tweak something before going into your next transfer, as opposed to kind of repeating the same protocol. Now, I will say that sometimes you might have had something like a chemical pregnancy where you've had a positive beta HCG that's gone down on its own, or you might have unfortunately had a miscarriage after an embryo transfer. In situations like that, even though it's not the outcome that we wanted from a frozen embryo transfer, that is demonstrating to us that there actually has been implantation happening, like the embryo has implanted in the lining. So even though it hasn't been a successful pregnancy, in situations like that, your doctor might recommend doing the same protocol because there's been evidence of implantation. But most commonly, if you've had a transfer and you've had a negative pregnancy test, most common situation is your doctor might either order additional testing or might change the protocol before doing your next transfer. So that's the last question I have here, and it looks like we're out of time. If anybody has any questions, feel free to submit kind of a couple other questions here just for our last couple minutes. But otherwise, thank you so much for coming to the Q&A today. We will be doing regular Q&A sessions, and if you want to attend future Q&As and you want to ask more questions, we'll be happy to answer those for you at that time.